think Dr. Seth is now about to deliver calcium approach, decision-making process. We requested him to deliver a talk. He couldn't come personally, but he joined on Zoom. We have live cases coming up, sir. I think we request you to finish in 15 minutes. And we're eagerly wanting to listen to you. And thanks for your time again, sir. We have Ajay, Sanjog, Miraslo, Manatosh Panja, Kayur, all other in the panel, sir. Over to you, Dr.
Thank you very much.
Seth. Thank you.
Thank you very much. And I wish I was there with you all. And I just heard Ajay's talk, and I know he's had a long flight, but that was tremendous. Ajay, you're always a star. Now, I've been given the task of decision-making, algorithm, calcific disease. I'm going to dwell on this very important fact of imaging. You see it there, and your understanding of the devices. But the single most important message is do not implant a stent till the lesion is fully dilated in 2 orthogonal projection. And that would be a part of the algorithm of the devices which we have, specialty balloon, atherectomy devices, intravascular lithotripsy, and laser that we have for calcified lesions. You all realize that as we go along this path, we know that IVL more recently has had the ease of use, the least amount of training, a good deliverability, but I also want, and the lowest learning curve. But I also want to make you understand that as you move up this ladder from non-compliant balloons or specialty balloons like the cutting balloons and the OPN, and you move to rotational atherectomy, orbital atherectomy, laser, and IVL, that's also the increasing expense for a patient. IVL is probably the most expensive device we have at the moment in our armamentarium. So we've got to actually develop algorithms which are useful for India and understand the use of these devices adequately. I'm going to give you tips and tricks beyond the usual for each device and how do these devices fit into the my severely calcified lesion algorithm. I'm not going to discuss device synergy here for the because of the time. So scoring and cutting balloons, must tell you, I believe that they're great for fibrotic osteal ISRs and pre-DCB. They are also perhaps good for post-rota, but are little used for severely, heavily calcified lesions that we talk about, the difficult ones that we see. So for me, these are for mild to moderate calcification, if it was got to deliver or talk about calcification. As far as ultra-high pressure balloons are concerned, and I'm talking about OPNs, I want you to understand that, of course, they withstand high pressures, but are they truly non-compliant or better than non-compliant balloons? If you see the compliance chart of these, it actually parallels the non-compliant balloon. But at 25 atmospheres, it still retains 0.02 millimeter less than an equal-sized non-compliant balloon. So even the OPN does grow. And I think you got to keep that in mind. The good thing is that it can withstand high pressures, but even at 35 atmospheres, a 3 millimeter OPN is going to be something like a 3.35, and it's grown by 3.35 millimeters. And therefore, perforations can happen if you don't understand the use of OPN and if you don't understand the vessel size. So I would say safer than NCN balloons because they work better. They take high pressures. They're great for unyielding lesions, post-rota, post-IVL, for underexpanded stents, for heavily calcified lesions, all standalone, and for device synergy when used with IVL or rota. But best to use them on support wire. Use a 0.5 millimeter less than the vessel size and go up gradually to maintain pressures at 35 to 40 atmospheres, by which time there would be a 3.35 or 3 millimeter balloon would be 3.35 to 3.37, and maintain it for some time at those because it usually bursts beyond 40 atmospheres, though I have taken it up regularly to 45 atmospheres. It has got a poor rewrap profile and move it therefore from distal to proximal, but the guide would get stuck in when you moved it that way, and therefore be sure that you don't damage the proximal, especially left main and the proximal part of the vessels. And imaging is a must to understand the vessel size prior to going up to ultra high pressures. A bit about rota, and what you need to understand about rota is that it's great for nodular calcium in smaller vessels. It's great for eccentric calcium in smaller vessels because of the guide wire biases. Rota through tortuosis angulated anatomy is feasible, but then you want to understand guide wire bias. You want to be clear about halfway rota techniques, which means that you don't have to, in an angulated lesion, cross the angle completely. Just get to the angle and perhaps then balloon dilate it. You want to understand rota through guide extension catheters. and understand an algorithm of what happens if you're burring for 5 to 7 minutes and rota doesn't cross. A bit of, this is going to be brief, bit about the guide wire biases, which you need to understand. And perhaps this reflects this tortuous anatomy in two different planes, reflects this guide wire biases excellently. A 1.5 fiber is so biased that it actually tends to really go deep grooving into the adventitia and could perforate the vessel, as you can see on the right side, and followed by a 1.25 millimeter burr, which gradually takes those curves. And then this can be then followed by a 1.5 and stent, and you then have a perfect result. And you do the same on the diagonal